This is Duke University.
Rick and I have been working together for over 25 years. We've been working in this area for probably 5 or 6 years. And our past research interest was in quality. A lot of work was in that area. And we became a part of a team looking at healthcare quality. And eventually we moved into the area of what is the role of patient satisfaction in thinking about healthcare quality. And that turns out to be a really interesting area because it's an area where there's not a tendency to believe that the patient has much information of value that would be relevant to healthcare outcomes.
We started by looking at clinical measures, which are objective measures of quality, and tried to relate those objective measures to output measures that the hospital is interested in, such as mortality rates, readmission rates. And after we found a very strong relationship between objective measures of quality, namely did the doctors adhere to certain standard procedures, and the final outcome, we then started to look at patient satisfaction data. And to us, patient satisfaction data was another measure of what the firm was doing. In this case, it was in the eyes of the consumer or the patient, and not the eyes of the manager or the doctor. When we did the analysis, we found out that patient input was just as important, or maybe more important, than the objective measures that the hospital was measuring on whether the doctors performed their tasks. So on one hand, you have the objective measure of the doctor, and then the other one, you have the perceived goings-on as viewed by the patient. And the patient seems to be able to intuit what's going on, and also to capture measures that are not captured by the objective measures that the hospital measures. And in particular, the patient is telling you, the doctor is listening to me, the nurse is coming and answering the call button, all sorts of things that are not captured in the normal way the hospital measures their objective performance.
In the marketing world that Rick and I had been working in and studying quality and how consumers perceive quality, it's generally received wisdom that there can be a difference between how quality is perceived in the lab or by an engineer and how a consumer actually perceives quality. And so people in a lot of different domains have grown to accept the idea that you have to pay attention to the consumer perception of quality. At the same time, in the medical profession, the view was because patients don't know about what constitutes good quality, that maybe perceived quality was of less relevance, and that we should just be paying attention to adherence to clinical standards. But you have to understand that Rick and I came into this with the traditional business perspective that consumers have very important information to share with you about quality, and that consumer perceptions of quality are important. And so we went down a path that maybe someone with more training in the health area would not have chosen, but it turned out to be a very exciting and interesting path.
We wondered why the patient input was so important. And this really was easy to explain once we thought about the fact that the service being provided in a hospital is not just a service where the doctor cuts you up or gives you a pill or whatever. It is a doctor interacting with the patient. And we refer to this as the co-production of the service that's being provided. If you want to think of an example that might be relevant other than just in the hospital, teaching is really a very good one. So we could measure quality of the teaching experience by just the scores that the students have on a test, or whether the teacher comes to class on time, or whether the teacher has good PowerPoints. Those are objective measures. You can say the PowerPoints are good or bad, but there's more to the experience than that, those objective measures. So there are perceived measures also. When you have a student who's in class and the faculty member is making an explanation and delivering it in a sound way, but the student just doesn't understand. So the student goes up and speaks to the professor and says, I still don't understand this. And so the professor, using his or her knowledge, reframes the question and reframes the example and comes up with another way of explaining things. And hopefully this explanation helps the student out. So this is where it's a co-production. It's not that the student knows the answer, but the student identifies to the professor that they're having this problem, and then the professor can solve it with this added knowledge. You can take that same example to a hospital situation.
What we did was really very simple. We looked at 3 different treatment areas: heart attack, heart failure, and pneumonia. And we looked at 2 different kinds of outcomes: mortality outcomes and hospital readmission outcomes. And what we did was we said, okay, if those outcomes are in question, what's the relationship between adherence to evidence-based standards, and then was there any role left for patient satisfaction? And what we found was, as we looked at the effect of patient satisfaction controlling for evidence-based adherence, that we found a very, very strong and powerful effect of patient satisfaction in these different treatment conditions with these different outcomes. And the effect was a very positive effect of patient satisfaction. In other words, the more satisfied the patients were, the more predictive that was of better outcomes in terms of reduced mortality and reduced hospital readmission.
If you think about it, a patient really understands their disease in some way as well as the doctor. They know where it hurts. They know their medical history. They know that they may be a little more sensitive to pain or less sensitive to pain, or that 10 years ago they did something or other that's not in the medical record. And unless the doctor and the patient communicate with each other, that information's missing. So this co-production is really measured through customer satisfaction or patient satisfaction.
The thing that's especially interesting to us is in terms of the relative size of those effects, that the size of the patient satisfaction effect is at least the size, if not bigger, than the role of adherence to clinical standards. And so what it tells us is that we have an enormous opportunity to improve the quality of delivered care by both paying attention to the clinical evidence, but also by listening to patients so that we can get the information that's of relevance in the co-production of this good.
So Bill and I are very excited about our research in that we think it is going to have major impact on the medical practice and the quality of care. Since the consumer or the patient is such an integral part of this, one of the questions is, how do you get good input from the patient? Currently, there are 2 ways that 2 major data sources that we use. One are private firms. One of them is called Press Ganey, who sends out surveys after you've been to the hospital. And any of you who've been in the hospital probably remember receiving some survey 2 or 3 weeks later, and the chances are you looked at it and threw it away, because the response rate for these surveys is about 2 to 5% of the patients fill it out. The other way is something called HCAHPS, which is done by Medicare, and they collect patient satisfaction data also for anyone that's on Medicare. And we use both data sets in our analysis. But if you think about this, the patient is filling this out anywhere from 2 to 6 weeks after the experience. And a lot has gone on since then, and most people don't fill it out. So recently, some firms that we've been involved with are trying to collect this data right after the experience. So picture a situation where you go to the emergency room, you have a problem. As you check in, they ask you for your email address and also whether you have a smartphone. And depending upon your response to this, as soon as you leave the hospital, within 24 hours, you receive a very short questionnaire asking you about your experience. Given that the response rate is going to be much higher, anywhere from 25 to 40% response rate, you don't have to ask a whole lot of questions for any one person. So you limit the number of questions asked, but because you have a large sample size, you can ask a large number of questions. You also know who is responding because they're sending back the email or answering off their smartphone. You can then tie that response to the providers. So now you have a direct link between the patient's perceptions of the service and the service provider. And now you're not scoring hospitals on service quality, you're scoring the individual. And now you can get at who is providing the service best, at least in the eyes of the patient. And you can take remedial action quite quickly. So this is a really good way of using our finding that patient input is important and tying it to the direct service provider.
So we do think that these findings suggest that there is an enormous opportunity to improve the quality of delivered care by using patient-centered information. We think that there's some clear insights about what you want to do. That for one thing, so that we don't get tangled up in the wrong kind of argument, that when we collect the patient information, it really should be information of relevance to the healthcare delivery process, as opposed to did you like the pretty colors in the hospital, and did you like the people who smiled and greeted you, and it should be more focused on getting information about the quality of the patient interactions with the healthcare delivery team. And so we think that focus is good. We think it's also important to keep the linkage between the measures, the patient-based measures, and the actual experiences closely tied, so that you don't have patients essentially giving you reports on some other kind of experience that may be of less relevance. And so we think that there's some opportunities in terms of improving the technology behind the ways that we collect the patient-based experience. But fundamentally, it's let's start using the information that we have to think about how those measures tie to the ways that we deliver the healthcare experience for patients.